general guidelines for the extraction. This is proposed by the Prophet. Less than 4 millimeter. Most of the time, you do not need extraction in most of the cases. However, if there is severe proclination, if you have a severe proclination or severe vertical discrepancy, the vertical discrepancy can also be affected by the tooth extraction. If you extract the tooth more posteriorly, for example, if you are having an open bite and the posterior teeth are touching to each other at the point of at the level of the second molars, so extraction of the 6 or extraction of the 7 would have like a wedge type of effect, and it may affect the vertical proportion. Sometimes you have to do the extraction for the midline where you don't have the crowding. So instances you have to do extraction for vertical, for severe proclinations, for some midline where you have less than 4 mm of crowding. However, as per the general rule, in the most of the cases, you can treat a case very confidently and very surely where you have around 4 millimeter of the crowding without doing any extraction. The 4 millimeter of crowding arch line discrepancy can be managed on a non-extraction basis. However, if you are having moderate level of crowding, the moderate level of crowding is from 5 mm to 9 mm, and this level extent of the crowding can be managed in both ways, by the extraction of the teeth and without the extraction of the teeth by the expansion. However, you make this decision of doing the extraction versus non-extraction based on the soft tissue parameters and soft tissue finding, and these soft tissue parameters are the thickness on the lips, tonicity of the lips, the nose morphology, the prominence of the nose, and the protrusion of the nose, the morphology of the chin, the soft tissue thickness of the chin, the amount of the buccal corridors. If you are having a 5 to 9 mm of the crowding, this decision depends upon the soft tissue parameters and the hard tissue parameters as well. Hard tissue parameters, how much the teeth are proclined or retroclined in the alveolar housing. In a similar way, if you are having a very protrusive upper and lower incisors and you are having a 5 mm of crowding, definitely this treatment has to be done with extraction, because the 5 mm the crowding is to be relieved. The other is you have to bring the teeth backward in order to bring it back into the proper position in the alveolar housing, okay, or to bring them in a normal inclination. But if you are having more than 10 mm of the crowding, this 10 of the crowding is like a for sure case for the extraction, because if we do 2 premolar extraction in any arch, you would get around 14 millimeter of the space, and if the crowding is around 10 millimeter or more than 10 millimeter, then the 14 millimeter of the space that you will be gained by the extraction of the 2 premolar is 10 mm will be gone in the relief of the crowding. So you would be having 2 millimeter per quadrant, 2 millimeter on the left side, 2 millimeter on the right side for the management of the other thing. Definitely you cannot do any significant changes in the face with the 2 millimeter. Okay, so the point is this, that if you are having 10 millimeter of the crowding or more, then the effect of the extraction on the face would be negligible and is not going to produce any kind of the results on this. However, the second premolar and the molar extraction is rarely satisfactory because they are so much away from the crowding area. Extraction should be performed as close as possible to the concerned area. For example, if you are having crowding in the lower labial segment, then definitely you will be extracting the lower first premolar, the more closer to the concerned area. If you are having so much proclination of the upper and lower teeth and your objective is the retraction and of the proclined teeth, so obviously you would be extracting more closer to the anterior zone, and their extraction choice would be in the mid arch. If the minimal space is required in the anterior zone, then your choice would be second premolar. For the second premolar is normally used if you have a posterior crowding, and posterior crowding means the premolar are crowding and the molar are not in a proper position. If you are having dental protrusion plus crowding, as we discussed here, okay, if you are having dental protrusion and crowding, so you do extraction for space and you do extraction for the face. So space mean you need extraction space for the relief of the crowding. You do extraction and you relieve all the crowding, meaning space would be available for the correction of the dental alveolar protrusion. If you are having 10 millimeter of crowding, then the 14 millimeter of space that you will be gained from the extraction of the premolar, 10 millimeter would be gone for the relief of the crowding, and the 4 millimeter would be available for the correction of the dental protrusion. So you cannot do a significant effect on the lips or on the face. This, for example, you have an arch form like this. Okay, for the retraction of 1 millimeter, For example, you have to reduce the overjet by 1 millimeter. So for the 1 millimeter, you need 1 millimeter of space here, and you need 1 millimeter of space here. So its mean is this, that for the 1 millimeter retraction of the incisors, you basically need 1 millimeter on the left side and 1 millimeter on the right side. So for 1 millimeter of overjet reduction, you need 2 millimeter of this space. 2 millimeter space is required for the 1 millimeter retraction of the anterior segment. So if you need to, for example, if I ask you how much space is required for the overjet correction of 6 millimeter. So for the overjet correction of 6 millimeter, the normal overjet is 2 millimeter. So my objective would be from 6 millimeter, I want to bring my incisors up to 2 millimeters. So I need to reduce the overjet by 4 millimeter. For the 4 millimeter of overjet correction, I need 8 millimeter of the space. It's clear? So moving on, as a general rule, the rule is this, that if the lip are incompetent and the lip are very responsive to the incisor position, normally the incisors, if the incisors move 3 millimeter, the lips will move 2/3 of whatever the incisors have been retracted. For example, with the 3 millimeter of the retraction of the incisors, you will be having a response of 2 millimeter on the lips. Okay, moving on. This is just a generalized point. This rule is not applicable everywhere. For example, the very important variables are the thickness and thinness and tonicity of the lips, as well as the competency of the lips. For example, if the lips are thick and competent to each other and the lips are touching to each other, if you retract the incisors, the response will be completely different as compared to the patient who are having lip incompetency and thin and hypotonic lips. That's the point.